to the in progress. Welcome everyone to the Central Clinical School seminar series, which, as you we should all know, is a new initiative this year to highlight the research being done across the very diverse departments we have in our school, with each department given one chance to showcase some of the research in their departments each year. I'd like to start by acknowledging the Burrong and Wurundjeri clans of the Kulin Nation, who are the custodians of the lands and waters on which we're meeting, and pay our respects to our elders past and to their elders past and present. Unfortunately, it's sorry that we have to do this one as a complete Zoom meeting, just in terms of our COVID wave, which thankfully seems to be settling down. So hopefully from next week, next seminar series in 2 weeks' time, we'll be able to meet again face to face. So this week's Central Clinical School seminar series is being put on by the Melbourne Sexual Health Centre. So I'll pass over to the head of department, Professor Kit Fairley, to introduce speakers for the day for the seminar. So Kit.
Right. Thank you very much, Terry, and welcome everybody. I'm very pleased to have two of our brightest stars to present to you today. We're located over in Carlton, which is probably why you don't see us very often. First of all, Associate Professor Jason Ong is going to talk on can we end HIV transmission in Australia. Jason has an appointment at Monash and also at the London School. He's a health economist and a sexual health physician with a very broad range of expertise and huge number of international collaborations. So we'll hear from Jason first, then we'll move on to Professor Catriona Bradshaw. She has an MSHC investigator grant and is going to talk on the impact of antimicrobial resistance on the control of gonorrhoea and Mycoplasma genitalium, but she has a lot of work in bacterial vaginosis as well, and is well known for her translational research in the treatment of these conditions. So I'll hand over to you, Terry, who'll then start Jason's talk. Thank you.
Okay, we might head directly to Jason. You're sharing a slide? Yes, I can see that. That's well.
Yeah.
Great.
All right. Thank you, Terry, and thanks, Kit, for the introductions. So it's a real pleasure to share at this meeting today. So I want to give a brief introduction to Melbourne Sexual Health Centre for those who don't know us, and also this tantalizing question: can we actually eliminate HIV transmission in Australia? So I want to acknowledge the Boon Wurrung and the Wurundjeri clans of the Kulin Nation, who are the custodians of the land and waters, and pay our respects to elders past and present. So just a brief introduction to Melbourne Sexual Health Centre. So we are part of the Alfred Health and part of the Central Clinical School. But as Kit said, we're actually based away from most of you in Carlton, but it's a lovely part of town. So do come around and visit if you want to. We offer a whole range of free sexual health services, and we are the only kind of public system in Victoria to do free testing, STI testing, and also what we call the green room for people living with HIV. So we have over 1,000 people coming to our service, counseling, and we have on-site pharmacy and laboratory. We have a really nice website, so if you want to learn more about us, mshc.org.au. Hundreds of people a day go onto our website, so it's a very popular website to look for resources. And a quick snapshot of us: we are a very busy clinic, over 50,000 consultations a year. We have a team of 26 doctors, 38 sexual health nurses, and you see the counselors and staff members who are supporting us. And lots of research, and I might be biased in saying this, but we really do punch above our weight in terms of the number of researchers we have and the kind of global influence our research has. So last year, we have, over the years, actually exponentially increased our publications as well. Just a brief flavor of what kind of research we do. So we do a lot of epidemiological studies with various databases. We also help with evidence synthesis and systematic reviews, and some of that we work with the World Health Organization on. And we also have established a health economics unit, so cost effectiveness and modeling, with also into artificial intelligence modeling as well. We also do a lot of clinical trials. And on the right, you'll see, I won't read all of that, but just a flavor of the kind of research that we get involved in. So again, all this information is on our website, so you could have a look more if you're interested. So I'm going to move on to the second part of my talk in the next 17 or so minutes, and ask this question: can we actually eliminate HIV transmission in Australia? Just stepping back globally, we still have a lot of disease morbidity related to HIV. So it is hopefully not the forgotten virus, but we do need to keep our eye on the ball. So currently 38 million people live with HIV. And you can see the new infections are still really high, 1.5 million new infections each year. And still many people are dying from AIDS. And if you kind of work out the maths of that, is usually it's about one person dying from AIDS per minute. So it's still quite a nasty disease. And our part of the world, we're actually second in terms of the numbers of people living with HIV. So obviously Southeastern and Southern Africa has the most burden of disease, but we also live in a part of the world that has 6 million people living with HIV. So in some ways, this is an epidemic curve. I think many of us are very familiar with these now, but you can see over the years, HIV, number of new HIV infections has tended to go down. But you can see that little red dot at the bottom right. That's actually our target. And you can see that if our current trajectory is what it will continue to be, we'll actually miss our targets. So this is quite an important slide. And in fact, UNAIDS in their report this year has alerted the world that we are actually in danger of losing all the gains that we have gained over the decades if we want to truly eliminate HIV. And in fact, the world is moving backwards in some ways in terms of HIV control. And one of the major reasons is the inequalities that have been uncovered with COVID, but also continue to fuel the epidemic of HIV around the world. Particularly structural barriers impede our progress. And we're talking about systems, not kind of blaming the individual, but building systems or having systems currently that are inadequate to address this issue. And obviously, stigma and discrimination, unfortunately, continues to be a major driver of new HIV infections around the world. So if I can leave with you this message that the AIDS crisis is actually not over. People are continuing to die. And as I said, 1 minute, another death from AIDS. However, I don't want to leave you with a bleak outlook. So I think there is optimism in the air. And this was from several years ago from one of our colleagues at the Alfred Hospital, Associate Professor Edwina Wright, who had a nice write-up in the New York Times. And this tantalizing question, as I pose to you, is could Australia actually eradicate HIV transmissions? So I want to also ask the question, could we be the first country in the world to eliminate HIV transmission? So when I talk about elimination, I'm thinking about this target of 0 local transmissions. So in some ways, it could be feasible for blood transfusions, mother-to-child transmission, and IDU, but we do have a lot of a harder struggle with sexual transmission of HIV. And here are our kind of latest figures nationally of new infections of HIV over the years. And just to demonstrate this, that we have very little HIV related to kind of blood and tissue receipts, as well as mother-to-child transmission. So it's within grasp that we can make this truly 0. Similarly with injecting drug use, so even though there's still this low level of infections, again, it's kind of close to 0, and I think we can reach that 0 transmission target. In contrast, you can see with male-to-male sex and heterosexual sex, the numbers are a bit higher, but also encouragingly, they are starting to drop as well, particularly for male-to-male sex. Not so much for heterosexual sex, which is still quite stubbornly around the 200 mark. And we do have evidence around the world, actually at the city level, that it's possible to dramatically reduce new HIV infections. So let me demonstrate a few data points here. So this is from New York City, and you can see in all the various boroughs where on your left-hand side, you can see the trends of new HIV infections over time. And remarkably, amongst men who have sex with men, that top blue line, it's starting to decrease quite dramatically. And similarly, in San Francisco, you can see that over the last 10 years, numbers are starting to drop as well, which is, again, remarkable. This is in London. So you can see, if you look at the blue line, that's the new HIV diagnosis over time. So in the x-axis, you can see from 2015 onwards. And again, you can see this dramatic drops. So it is possible to, for this kind of dream of ours to kind of reduce HIV transmission. This is us in Australia. Again, you can see the number of new HIV infections over time. The top dotted line is the total number of new infections. And then the one below that is amongst men who have sex with men. So again, you can see that kind of significant drop. The challenge, however, for us is to get this down to 90 new cases by 2030. So how do we actually get there? We, in fact, do know how to do it. The challenge at the moment is to implement our knowledge. So the science is there and the science is in. And we actually do have a lot of really amazing tools to end HIV transmission. And the biggest ones that I would kind of put forward, if you're not aware of it, is something called U equals U. So undetectable equals untransmittable. So getting people living with HIV onto treatment, which is life-saving for themselves, but also makes them untransmittable to their sexual partners. That's an amazing piece of news that is kind of has helped with those dramatic drops of new HIV infections. The second major piece, I believe, is PrEP, or pre-exposure prophylaxis to HIV. And that is, again, better than any vaccine because up to 99% effective to prevent HIV transmission in someone at risk who use PrEP properly. So these two pieces, together with many other kind of pieces or the tools that we have, can essentially end our global HIV pandemic. Let me ponder a little bit on the Australian response. Particularly for us, we are certainly regarded as one of the world leaders in HIV response. Very early on in the 80s, we had a very strong community-led response that works very closely with scientists, with clinicians to ensure that people got the right treatments and that there's no, well, they tried to minimize the stigma around it as well. And Australia is the envy of the world in terms of how we responded and how we partnered with communities. And things like free condoms, harm reduction kind of strategies like clean needles really prevented the epidemic amongst people who inject drugs to accelerate, unlike other parts of the world. So that really helped us in terms of our control of HIV early on. And as I said, the ongoing strong response, so U equals U. Again, we are the envy of the world in terms of the numbers of people on treatment. And that means that there is less community transmission as we can get more people onto treatment. And we've had some recent victories as well. So in particular, the latest one, and perhaps not everyone is aware of it as yet, but last year in December, the government decided that they would provide antiretrovirals under the Medicare scheme to all people living in Australia, regardless of their visa status, which is a huge win, which means that it removes a lot of the barriers and fear from people who are not Australians or not able to access Medicare to be able to now access these antiretrovirals. So that just recently happened, which will help us. And then PrEP on PBS, that's actually been available since 2018. But unfortunately, many GPs are still not aware of it. So there's a lot of PR work that we need to do to get people who need PrEP or who would benefit PrEP onto PrEP. Here are some numbers just to show you our PrEP uptake around Australia. This is only the ones related to PBS prescriptions. But again, we are the envy of the world in terms of how Australia has really scaled up PrEP. But we must not rest on our laurels. I think even though we've done all of these really amazing things over the last few decades, and I certainly do stand on the shoulders of giants. I mean, I only came into this field maybe 10 years ago, but already there's been so much work that's been done in this area to give us where we are today. So I would challenge that a lot more work needs to be done by us, even though we are doing well as a country, but to kind of finish off that last mile, there still needs to be a lot of work. So the winds are changing in terms of our HIV epidemic, in how HIV affects different parts of our communities. And not everyone is benefiting equally to these amazing tools that I just outlined before. Again, it's about inequities. So there are some subpopulations that still remain at risk where there is no change in their notifications for HIV, or even rises over time rather than decreases. So the overseas born men who have sex with men is certainly a major focus in my research, and also a key group that we need to focus on. And also other groups that we need to look at, travelers, heterosexuals, people who inject drugs, and First Nations peoples. So we do still have this kind of stubborn number that doesn't seem to budge much. This 10% of people living with HIV who remain undiagnosed. And there's been some mathematical modeling done in this area that says that, you know, they're actually contributing to the majority of new infections. So it's really critical to be able to chip away at this group. And just to show you some statistics related to overseas born gay bisexual men. So on the top right, again, you can see the kind of divergence of the Australian born gay bisexual men. So showing that marked decrease of new infections. However, with overseas born gay bisexual men, you can see that the numbers actually are kind of not going down or even increasing over time. And at the bottom there, you can also see the proportion undiagnosed is unequally affecting overseas born gay bisexual men. So you can see, particularly Australian born gay bisexual men, we've done really well. It's probably less than 3% at the moment who are undiagnosed. However, for those who are overseas born, it's like 16% or even higher in certain subgroups. So there's a lot of work that needs to be done in that area. And here's another way to look at the data. So thinking about the new infections amongst Australian born, so 2 per 100,000, but look at the overseas born. So it's 4 or 5 times higher in those who are born overseas. And what do we actually need to eliminate HIV? So this is a special issue that we published in the Sexual Health of a collection of various articles. And just to remind us that we do live in a connected world. So yes, we can do all these things in Australia, but we do also need to assist our countries around us as well if we are truly to end HIV transmission in Australia, but also around the world. So is it possible to end HIV? I think so. I am an optimistic person. So we have set our targets as 2025 to do this, so which is not long actually, so 3 more years. And there are a few things we need to do, and this is just my 2 cents. So again, we need to stop doing stigma and criminalization of sexual minorities. I know that's harder to do than actually me saying it, but yes, we need to keep that at the top of our list of things that activities that we are doing. Keep funding prevention and management programs. Yes, there are extra priorities because of these pandemics around the world, but if we don't want to go backwards in HIV control, I think we need to keep the funding going. I talked about U equals U. That's an important message to go out into the community, and that also helps with reducing stigma around HIV as well. I think we need to do a lot better in terms of reducing incidents, which are the new infections, particularly in the subgroups I mentioned before. Access to PrEP and HIV self-testing, kind of new shiny tools that we have, and currently subgroups may not have access to these shiny new tools. So we need to improve access to that, and continuing to monitor and evaluate. So I'm a data nerd, so I do like to look at figures, and certainly, as you can see, by having that data, we can actually show you what's happening under the hood in terms of HIV control. This is one of my last slides. So we actually, the Australian Federation of AIDS Organizations have actually put this Agenda 2025, which is a fully costed strategy to really end HIV transmission in Australia. So there are, it's not just me, but there is optimism in a lot of people that we can actually do it. But we do need to kind of, as I said, run that final mile. So with that, thank you everyone for your time. We will have a Q&A at the very end, so please do keep your questions for that, or if you put your questions in the chat box, I can kind of answer along the way. But I will now pass the time to Professor Bradshaw.
Thanks, Jason, and for that really great overview. Okay, can you see my full screen?
Yep, looks good.
Perfect.
Good.
So I'm going to be talking today on the impact of AMR on the treatment and control of our 2 most problematic STIs, so Mycoplasma genitalium and Neisseria gonorrhoea. So I'd like to acknowledge the Bunurong and Wurundjeri clans of the Kulin Nation, who are the custodians of the lands on which we meet today, and to pay our respects to elders past and present. So both gonorrhoea and Mycoplasma genitalium were placed on the antibiotic resistance threats list by the CDC, and gonorrhoea is considered an urgent threat, and Mycoplasma genitalium has been placed on the recently created watch list. We have a WHO Global Action Plan to control the spread and impact of AMR and gonorrhoea, but we do not have a plan for Mycoplasma genitalium. And we do have a WHO gonococcal antimicrobial surveillance program, and this is a culture MIC-based program and reports the percentage of isolates with decreased susceptibility or resistance to ceftriaxone, ciprofloxacin, and azithromycin, so the main drugs that we use to treat gonorrhoea globally. Most people are very familiar with this slide. It shows the evolution of AMR in gonorrhoea and is a quite depressing picture, and really shows how rapidly we've lost some antimicrobials almost as soon as they were introduced, so the sulfurs and ciprofloxacin and azithromycin. And this is because gonorrhoea accumulates resistance determinants, and we have really got to the point over 80 years that we're on our last drug. But AMR in gonorrhoea is complex and it's heterogeneous. Some drugs are a little easier than others. And so for ciprofloxacin, we actually do have a single molecular marker of susceptibility and or resistance. So at codon 91 in gyrase. So a mutation at that site has a really excellent positive predictive value for failure of Cipro, and being wild type or absence of the mutation is highly predictive of susceptibility to Cipro. And we have a new commercial assay for this Cefixime is a little more complex, and reduced susceptibility is determined by any of 6 mutations in the PEN-A gene, while ceftriaxone reduced susceptibility is determined by mutations in any of 4 genes, so PEN-A, PEN-B, PON-A, or NTR. Now, I have tended to focus on Mycoplasma genitalium, which is an organism that really poses quite different challenges for treatment and control in gonorrhoea. Firstly, it doesn't have a cell wall, so we have really a lot fewer antimicrobials with activity against MGen. And we rely on those that inhibit protein synthesis, so act at the bacterial ribosome, so macrolides, ketolides, streptogrammins, to a lesser degree tetracyclines, and those that inhibit nucleic acid replication, so target DNA gyrase or topoisomerase enzymes. And commercially, we really have fluoroquinolones for this, but we do have a couple of other candidates in the pipeline. This is an organism that is really fastidious. It grows very slowly. It's very hard to culture. There's only a few groups internationally. We've finally got isolates growing in Melbourne in the last 12 months. But we really have quite limited MIC data. It has an error-prone genome that has really facilitated the development of AMR. So for macrolide resistance, any of 6 mutations in the 23S ribosomal RNA gene impart really high-level resistance to azithromycin, while reduced susceptibility or resistance to fluoroquinolones is a lot more complex. It's poorly understood and largely mediated by PAR-C mutations, and to a much lesser degree, GyrA. So there hasn't been a lot of AMR data for MGen, and 3 or 4 years ago, we embarked on a meta-analysis with Dorothy Matulek at the Kirby and reported widespread and increasing macrolide resistance in MGen globally. Importantly, we saw an increase from 10% to 50% over the decade, but up to 70% prevalence of macrolide resistance in the Western Pacific. And you can see the countries in dark brown have macrolide resistance in excess of 50%. So our region, North America, and some countries in Europe. There's an absence of data from large parts of the world, and we're in the process of updating these. We've not generated pooled estimates yet, but I've just popped in some general impressions from the publications, and we can see we're slowly starting to fill in some gaps, but we have really concerningly high rates in our regional neighbours. Now, PAR-C resistance or fluoroquinolone resistance mutations, there were a lot less data at the time we published the meta-analysis. The same countries that had the highest estimates of macrolide resistance have the highest estimates of quinolone resistance, so in excess of 10% in our region and North America, but a lot less in Europe. And since we are in the process of updating it, we've seen a lot more publications coming in, and really concerningly at high estimates in excess of 50% in Asia, and our estimates have gone up to 20 to 30% in our region, and we can see some higher estimates coming in Europe. But these will be updated formally shortly. Obviously, AMR is a consequence of antibiotic consumption, so it's related to overuse and misuse, but also drug characteristics. So drugs that have long half-lives and long subtherapeutic tails like azithromycin really rapidly generate AMR. And we've seen a rapid rise in macrolide resistance in gonorrhea, MGen, and syphilis that's been directly related to azithromycin consumption. Firstly, we've used 1 gram azithromycin very widely globally in the syndromic treatment of STIs. We then used it first line for chlamydia and MGen and within gonococcal regimens. And we've seen a very rapid decline in azithromycin cure for urogenital MGen over a decade. So cure rates in excess of 80, 90% that rapidly fell to less than 50%. And this is because we get a very high rate of in vivo selected resistance. So 10 to 12% of infections develop detectable post-treatment resistance just following a single 1 gram dose. Obviously, AMR is going to continue to rise unless we review policies and the evidence for our practice. And I think without doubt, our current practices in sexual health really promote AMR. We've had a preference for single dose, long-acting oral antibiotics for STIs globally. We've practiced syndromic above etiologic approaches, And we've really promoted very frequent screening and treatment of STIs in subgroups, perhaps without the evidence to support that practice. Certainly, frequent screening for chlamydia and gonorrhoea in MSM has not been shown to reduce the incidence of these infections. It has been shown to increase antibiotic consumption. So macrolide consumption in MSM in some European countries is 50 times that of the general population. It has been shown to increase MICs in gonorrhoea and molecular markers of AMR in MGen and syphilis. Ecologically, macrolide consumption is really strongly associated with the prevalence of macrolide resistance in MGen. So this little figure on the bottom right from Chris Kenyon's group shows a very strong correlation with Australia sitting right up there at the top. And one of the difficulties we have with MGen is it's actually very common as an asymptomatic infection in MSM. It's present in about 10% of asymptomatic MSM who walk in the door at Melbourne Sexual Health Centre. And if you're using azithromycin widely to treat other STIs, it's going to be inadvertently exposed really commonly. And with these high rates of selected resistance, you can see how rapidly macrolide resistance gets generated. Obviously, there are other practices that are really quite detrimental for AMR, using antibiotics as prophylaxis, using antibiotics in mass treatment programs. And I think it's time for us to really ask ourselves, have we really given sufficient consideration to the collateral damage? So induction of AMR, impact on commensal bacteria and the gut microbiota, and the fact that we really have limited drugs left and very few in the pipeline. We add to that the impact of widespread use of antibiotics in food-producing animals on human pathogens, and we certainly know that contamination of food sources with drug-resistant bacteria in our regional neighbours is really posing a very immediate threat to human health. So we do need to prioritise measures to mitigate AMR and sexual health, and it does rather mirror that race we have against climate change. So we have an obligation to try and use antibiotics more responsibly and move away from blunt tools like syndromic to etiologic approaches where possible. And we certainly entered an era where we do understand the mechanisms of AMR and STIs. So we can now identify new biomarkers of antibiotic resistance, but also susceptibility in STIs using a broad range of tools. So we no longer have to rely just on culture and MICs, but we can use genomics and sequencing. And this enables us to develop diagnostics that provide profiles that improve precision in antibiotic prescribing and reduce antibiotic misuse and overuse, although this is more challenging for some STIs than others. So we adapted our treatment strategies for MGen to rising AMR, and we really saw high levels of macrolide resistance and rising quinolone resistance over the last decade. So in 2014, we decided we really needed to act. So we stopped using azithromycin for our syndromes and we switched to doxycycline for these symptomatic patients. We collaborated with an Australian biotech to develop a macrolide resistance assay for MGen. And this targets 5 to 6 of the SNPs in the 23S ribosomal RNA gene that individually each impart high-level macrolide resistance. So for our macrolide susceptible infections, we sequenced high extended dose azithromycin directly after doxycycline. And for the macrolide resistant infections, we sequenced moxifloxacin after doxycycline. So this is how our first generation of resistance-guided therapy for MGen looked. People come in with their syndrome, they're tested for chlamydia, gonorrhoea, MGen, plus a macrolide resistance profile. Our non-gonococcal syndromic patients are placed on doxy, and then they're recalled while they're on doxy if they're MGen positive and therapy is individualised. The macrolide susceptible patients go straight onto 4 days of azithromycin, which achieve 96% cure, and very importantly reduce this de novo or selected resistance from 12% down to less than 4%. Our macrolide resistant infections go directly onto doxycycline, which in our hands achieved 92% cure. But importantly, cure in that group is determined by the prevalence of PAR-C resistance mutations. So when we sequenced these macrolide resistant infections for quinolone resistance mutations, we found really concerningly that 20% of the infections had a PAR-C mutation and 13% the key S83I mutation, which I'll discuss shortly. So this sequence resistance-guided strategy increased first-line cure from 50% with 1 gram to more than 90%, reduced de novo macrolide resistance, and had a really rapid impact on policy and practice. Obviously, sequential monotherapy isn't optimal for organisms prone to developing AMR, so combinations of agents are often used to limit the development of resistance in infections like HIV, malaria, TB, MRSA. So we did have some in vitro evidence of synergy for doxy and azithro with macrolide susceptible strains, and some for doxy-moxy, but not in strains with really high MICs. So during COVID, we embarked on a third resistance-guided strategy, resistance-guided combination therapy. We aim to evaluate the efficacy and tolerability of sequential combination therapy with 7 days of doxy, followed by combined doxy-azithro for 4 days for our macrolide susceptible infections, or combined doxy and moxy for our macrolide resistant infections. A really important aspect of this was to look at the impact of key PAR-C mutations on moxifloxacin outcomes. So the pathway really was identical, except when we recalled our MGen infected patients on doxy, they got combination therapy if they were macrolide susceptible with doxy-azithro, and this achieved 93% cure. If they were macrolide resistant, they got combination doxy-moxy, and this really disappointingly achieved 85% cure. So while in fact these differences weren't statistically significant to sequential monotherapy, there was no clear advantage. And in fact, when we sequenced the macrolide resistant infections, we found a marked increase in quinoline resistance from 20 to 30%, and an increase, a doubling of the key S83I mutation to 26%. So to date, we have really lacked the data to define the contribution of PAR-C mutations to fluoroquinolone treatment outcomes. Often data sets have been small, just reporting mutations with no outcomes. Mutations are often uncommon, and this has really impacted on efficacy estimates and predictive values for treatment outcomes, and really importantly hindered the development of really clinically useful assays. So we have felt for some time it's time to develop a strategy that incorporates fluoroquinolone resistance or susceptibility. So we looked at the impact of key PAR-C mutations on treatment outcomes across pooled data sets over the last decade. So we pulled our 3 resistance-guided cohorts, and it gave us about 540 cases with macrolide-resistant MGen, PAR-C data, and treatment outcomes for moxifloxacin. Firstly, what you can see is in blue, this really alarming increase in this amino acid change that reflects a key mutation that is associated with reduced susceptibility to moxifloxacin, and it's gone from 13 to 23%. The other mutations in the S83, D87 regions are relatively uncommon with no obvious trends. So we were very keen to look at the best predictors of moxifloxacin failure or cure to help us come up with an in-house assay and also a commercial assay. So firstly, when we looked at the S83I changes, S83I was the most common mutation, and 60% of those fail moxy. The other mutations are a lot less common. And you can see that perhaps R is the next most clinically relevant, with half failing, but still uncommon and no trends over time. When we look at the D87 mutations, N is the most common, but really rarely associated with failure. The most useful piece of information to come from this is actually being wild type. So an absence of any mutations in the S83 or D87 was associated with a very high probability of cure. So you could use moxifloxacin with a lot of confidence here and know that 98% of your cases will be cured. If you're wild type for just S83, it's still good with 96% cure. So pooled data has really confirmed the value of a dual class resistance or susceptibility assay to improve stewardship and cure. Our priority markers are really the existing macrolide resistance mutations, but probably adding an S23S wild type profile. The S83I mutation stands out, but having an S83 D87 wild type profile would really guide clinical care. So this is how our next pathway will look. We're working with MDU to develop an in-house assay. We're also working with SpeedX to develop a commercial assay. So patients come in, they're tested for chlamydia and gonorrhea and MGen. Their macrolide and fluoroquinolone susceptibility and resistance profiles are reported, started on doxy and recalled if they're MGen positive. Now, we know with confidence if they're macrolide susceptible, we can give them a 4-day regimen of azithromycin directly after doxy. If they're macrolide resistant and S83, D87 wild type, we can give them moxy with confidence, and both are going to achieve a greater than 96% cure. So ultimately, you would not need to get these patients back for a test of cure unless they've got ongoing symptoms. Macrolide resistant and S83I mutant patients are a little trickier because we have few drugs in our toolbox, but we do know that citalfloxacin has better MICs for Par-C resistant strains. So if we combine it with doxy in our hands, this has achieved more than 80% cure. Minocycline and pristinamycin, we've generated data to show cure is more than 70, was in the order of 70 to 75%. Now, obviously, resistance guided therapy at point of care is the ultimate game changer, and we do have this opportunity in a TGA-approved adaptation of the SpeedX resistance assay to the Cepheid GeneXpert flexible cartridge. So this is a point of care macrolide resistance assay for MGen that performs reasonably well against Sanger sequencing. We evaluated this last year in clinic at Melbourne Sexual Health Centre. It's a bit more manual, this version. You need to use a range hood and have a reaction mix, but the next version will be all integrated into one cartridge. This particular one is a bit slower. It's 2.5 hours. But, you know, it does enable you to dispense with syndromic management, clearly has an impact on prescribing, partner notification and cost effectiveness. We're evaluating all of those things in the study at the moment, and Jason is actually doing the cost effectiveness analysis. It has the potential to improve stewardship and may reduce overall health costs. Lastly, AMR surveillance is obviously key to antibiotic stewardship, and we need to be agile and to adapt treatment strategies and diagnostics to changing trends in AMR. Now, obviously, with gonococcal AMR surveillance, we do have a national and a WHO program that's culture and MIC based, but we do have an opportunity for molecular surveillance for gonorrhea and MGen, and we have increasing numbers of tools. So we can move away from Sanger sequencing. We've got amplicon sequencing, long-read nanopore, even whole genome sequencing. We're in the process of setting up national MGen and AMR surveillance to generate epidemiological and resistance data to directly feed back to improve clinical care, antibiotic use and AMR. And our collaborators, Dorothy and Athandi at the Kirby and Jason and Michael at Burnett, have been doing a lot of heavy lifting to get this off the ground. So we do have limited antibiotics in the pipeline. So repurposing is obviously an important strategy. And we have generated data at Melbourne Sexual Health Centre on pristinamycin, minocycline and citalfloxacin for resistant MGen. Drugs can be recycled for gonorrhea if susceptibility re-emerges, particularly using that Cipro susceptibility assay, have the potential to do this for drugs like gefixine. We do have 3 new candidates in the pipeline, gepotidacin, lifamulin and zoliflodacin. They have varying potential for gonorrhea and MGen, but obviously we need to avoid the mistakes of the past and not use them syndromically or in mass treatment or as prophylaxis. AMR surveillance and companion resistance assays are really integral to the success of these strategies, but also the longevity of these agents so we don't lose them. So in conclusion, rising resistance to current antimicrobials really necessitates the use of resistance assays in clinical care for STIs that are prone to AMR. Resistance-guided therapy using this sequenced approach with available drugs really dramatically increased first-line cure from 50% to more than 90% and changed international policy and practice. This rapid increase in quinolone and dual-class resistance in MGen in our region really creates a need for susceptibility and resistance assays for both macrolides and quinolones. And as I mentioned, we're developing an assay and collaborating with MDU and industry to develop a commercial assay. Once we have this in place, we can really individualise care, optimise selection of antimicrobials, reduce tests of cure, and has the potential to be cost-saving and promote antibiotic stewardship. And having this as a rapid test would further improve timely prescribing and stewardship. So lastly, I guess I'd just like to highlight that we're running out of time, and we do have a duty of care to use antibiotics responsibly and to be aware of AMR and undertake surveillance and use it to inform our national strategies in a timely way. We should be mindful of the characteristics of the drugs we use and their propensity to induce AMR, and move away from syndromic treatment where possible to etiologic and resistance-guided approaches. And adhere to indications for testing for STIs and not just multiplex things. Evaluate our screening policies in subgroups and consider the broad collateral damage of very, very frequent antibiotic use. Are these policies in fact doing more harm than good? We should engage stakeholders. AMR needs to be visible to both consumers and providers, and set reasonable expectations with patients to use antibiotics responsibly. So on that note, I would like to thank everybody listed here, my group, but also collaborators at the Women's, the Doherty, UQ, Kirby, our industry collaborators, and yes, this work supported by an investigator grant, but also an ARC Industrial Transformation Hub grant. And these are my disclosures. Thank you.
Virtual clap from everyone, Kat and Jason. That was really fabulous. Just now, can people either put up their hand? I've got see some hands up already. If I don't see you because we've got so many people online, don't be, and I don't call you, don't hesitate to just shout out. Actually, most of these look like they're claps. And also, if you like, you can type a question into the chat. But it'd be good to hear your question live if you're happy to turn on your camera and ask a question. So maybe while people are thinking, that's just this fabulous work, Kat, that you're doing and really make online with precision medicine. Which makes a lot of sense going forward, but the fact that the pipeline seems to be dry with new antibiotics, are we just holding off the impending disaster where we don't have effective antibiotics by this, or do you think that this is going to be a long-term sustainable strategy that will mean we will have effective treatments indefinitely?
Yeah, I mean, I think it's a good question. And obviously this is, it differs clearly between high, middle and low income countries and regions. So we're extremely well resourced in Melbourne, and we can implement effective assays. Our collaborations with, leading public health laboratories enable us to be really agile. And we in Australia actually can access more antimicrobials, which I'm starting to wonder whether that's a good thing actually compared to our neighbours, in Europe and the US. I think that the difficulties lie in large parts of the world where there are not clear alternatives to syndromic treatment at the moment. And obviously economic reasons why antibiotics are available over the counter and people share them. But, like Jason, I'm an optimist. I don't think we've run out of time. I'm sure Anton has some very pertinent points there because he works in the much broader AMR space. But I think, we can't give up. We have to try. And I was surprised at how rapidly our strategy got adopted internationally. So I think the field of providers are ready for this.
Great. Thanks, Kat. I do see Anton's hands up. So Anton.
Yeah, thanks, Jason and Kat. Really fantastic talks. Really, really enjoyed them both. I might just start a question for Jason. I came a little bit late, but I was seeing, the exciting data on obviously numbers of new HIV diagnoses, both locally but also internationally. I just wonder, it seemed like, at least what I was seeing, there were absolute numbers there rather than relative to a population? And I assume, how do we compare? I was just interested how we're comparing to some of these other countries. It was a bit hard to tell when you were using absolute numbers compared to relatives. So that would be really interesting. And I also, is there any updated data? I saw a lot of that was sort of ending, 2018 things, but the impacts of COVID, lockdown, post-lockdown. Obviously, we know that the STIs changed in other STIs changed through COVID, but just new diagnoses, if you've got updated data on that.
Thanks, Anton. If you wait 2 more weeks, we'll get new data from the annual surveillance from the Kirby. So that will be launched at the upcoming Australian HIV conference. I have been told a sneak peek that definitely, COVID has reduced numbers. So we have to be cautious with our numbers, I guess, over the last 2 years. There will be marked decreases in HIV notifications, and that's the COVID effect has to be played into that. In terms of your first question, yes, I didn't show that data, but the relative kind of reductions. When UNAIDS first set the 90% reduction goals, it was to a 2010 baseline. And so Australia is not doing too badly with that. I don't think we are exactly or close to 90%, but we are closer than many other countries. Thank you.
Right. And I see a question from Georgia for Simons. Georgia says, do you think that all at-risk groups should go on to PrEP for prevention? Would there be advantages or disadvantages to this?
Yeah, thanks, Georgia. Our Australian target is to have 90% of people at risk to be at least accessing PrEP. I think PrEP is a choice. It may not be suitable to everyone, but definitely if we can get a proportion of people, and there are some modeling studies to say exactly how much we need. 40 to 60% is what I've seen to truly get that turning down of HIV infections. But PrEP is also an exciting field at the moment in terms of choice, because not only do we have the daily and on-demand PrEP, the oral PrEP, but we also now have an injectable version of the PrEP. So I think by giving people who would benefit most these choices to prevent HIV, and some people may not use PrEP, but rather consistent condom use. So it's just providing people with that suite of choices. There is advantages and disadvantages. There's a lot to go into, but I would say that PrEP is a very safe drug. We've used Truvada for many years, and there are very little disadvantages with that. Thanks.
Great. Thanks, Jason. I see Anton's hand up again. Not a historical hand, Anton?
No, I just want to ask Kat a question as well, if that's okay.
Yep, go ahead.
Yeah, so Kat, really, it's fascinating to just look at the evolution of things. There's obviously a big focus on what to do with the patient coming in with a syndrome. And I wonder, and you're doing that so much fantastic work to try to streamline and target and personalize therapy to minimize resistance emergence, but also optimize success of treatment. I do wonder what you're thinking about upstream, so more on, I guess, prevention space. And I was just wondering about sort of transmission dynamics of MGen. So what do we know about dominant clones, and what are there characteristics of dominant clones that increase transmission potential? Are there other kind of pathogenesis-based ideas to try to sort of reduce those aspects?
Yeah, it's a really good question. So to date, a lot of the work has been done looking at typing. So, antigen-based markers that don't show any sort of particular patterns between heterosexuals and MSM or determinants of resistance. But of course, the next step is the genomics. And so that is actually starting now. And we'll be able to understand a little more about patterns of transmission and fitness. What I can say is that it is a different organism compared to something like gonorrhea, in that it is traditionally the lowest load organism of the three: gonorrhea, chlamydia, mycoplasma. It sits annoyingly often right on the threshold of detection of assays. It is not really transmitted through oral sex. It's very much through penile vaginal, penile anal sexual transmission. It's an infection where, when you look at the rates of, I can't tell you an attack rate, but if you look at the rates of infection in sexual contacts, which we've done, it's sitting around 40 to 50% of regular MSM partners and female partners will be infected. But when we're talking about heterosexual men and the urethral side, it's down to sort of 30%. So I haven't really directly answered that question in terms of clones, but I think there's a lot of work that's starting to emerge with, certainly at Vidril, they've just had some success with sequencing, with whole genome sequencing direct from clinical samples, which is going to enable us to look at the whole genome and start to do some of those studies that Deb Williamson has done for gonorrhea and syphilis for Mycoplasma genitalium. Does that half answer it?
Yeah, I think it does. I think it sounds, yeah, that sounds like interesting work in progress. I also wonder, with a 10% asymptomatic carriage rate, are there clinical matrices that could be, how do you, that's challenging, right? If you've got 10% of a carriage rate, and then you've got, common things happen commonly and they can happen together, but they may not necessarily be causal. Is that, is that a challenge in the area?
I think the challenge for us is to stop people screening for this infection, and we focus very much on testing of symptomatic individuals, of asking laboratories not to multiplex this organism, of asking people and providers, and writing guidelines and writing editorials. Do not multiplex, do not screen, stick to your clinical indications. There is no evidence in MSM, if this is asymptomatic at the moment, for significant harm, other than the psychological harm that people have when they find out they've got an STI. In women, it's a different issue, because PID, cervicitis are real issues, and potentially infertility, spontaneous abort and miscarriage. The odds are up for all of those statistically. So for women, we're not screening either, but we are keener to eradicate. For MSM, eradication is not a goal. And then obviously you then have bridging populations. So then you end up with leakage back into the heterosexual population. So it's got quite an insolvable problem, really. But throwing piles of antibiotics at people and subgroups like MSM, who already have incredibly high levels of antibiotic consumption, doesn't seem to be a satisfactory solution.
Great, thanks.
Great, thanks, Anton. And we've now come to 1 o'clock. So thank you so much to Kat and Jason. It really was an outstanding 2 presentations, and an outstanding CCS seminar presentation. As Jason outlined, the Melbourne Sexual Health Centre is the world leader in this space, and often I don't think gets the visibility within the school that you really, and the university you really deserve. So thanks for providing us that opportunity. And congratulations, Kit, on your leadership, and to everybody in the team. So next seminars is in 2 weeks' time. It's supposed to be medical oncology, chaired by Mark Shackleton, but we've just found out that he's actually going to be overseas. So watch this space. We're just trying to realign. If there's any departments who would like to present in 2 weeks, please let Michelle know. So hopefully we'll see you again in 2 weeks. And otherwise, have a great weekend, and we'll speak soon. Thanks, everyone. Bye.